Доброго вечора, радіаційні онкологи, медичні фізики та радіаційні терапевтичні технологи. Слава Україні! We are very happy to introduce the fifth lecture in the series of modern brachytherapy course with ABS experts for Ukraine. And I would give a word to Arjit to introduce the topic of the lecture and our speakers.
Hello, everyone. Happy to meet you all again. Today we have two really interesting and phenomenal speakers on prostate brachytherapy, which is an important topic. First, we have Dr. Martin King. He is an assistant professor at the Harvard Medical School and a board-certified radiation oncologist who specializes in treating GU cancers at the Dana-Farber Cancer Institute, Brigham and Women's Cancer Center in Boston. He completed his medical degree at the University of Chicago, internship at North Shore University Health System, and a residency in radiation oncology at Stanford University Medical Center, and a fellowship at Memorial Sloan Kettering Cancer Center. He now serves as the director of GU Radiation Oncology, as well as the Brachytherapy Clinical Operations Leadership Team at Brigham and Women's Cancer Center. Brigham team has treated between 120 to 200 patients with prostate brachytherapy every year for the last few years. Dr. King currently serves on the board of directors for the American Brachytherapy Society. Next, we have Dr. Ivan Buzurovic, is an associate professor of medical physics and radiation oncology at the Harvard Medical School and chief of brachytherapy physics at Brigham and Women's Hospital and the Dana-Farber Brigham and Women's Cancer Center. His work focuses on technological innovation and clinical translation in image-guided and robotic brachytherapy, with emphasis on automation, MRI-only treatment planning, and adaptive HDR techniques. He has led multiple funded research projects, including collaborations with the NIH and the Electra Brachytherapy. His contributions have been recognized with institutional and national awards, including the K Scholar, Takelet, if I mispronounce, I apologize, Quest and Pillars of Excellence Awards, as well as Distinguished Referee and Associate Editor recognitions from medical physics. Dr. Buzurovic serves as Senior Associate Editor for Medical Physics and Editorial Board Member for Brachytherapy, and has held editorial and conference leadership roles with the IEEE Engineering in Medicine and Biology Society. Nationally, he has contributed to AAPM, ASTRO, and ACR task groups, including TG56B, 59B, TG342, and the Working Group on Medical Errors in Brachytherapy. From a personal perspective, I had the privilege of spending a few days with both of them a couple years ago to see the amazing work they do at their clinic at the institution, and got to learn a lot. So it's an honor for the Ukrainian community to have such distinguished speakers. Thank you so much for teaching us today on prostate brachytherapy. The podium is yours.
Okay, thank you very much. So I'll go share my screen. Okay, so it's good to see everybody. I'm Martin King, and I'll be giving the clinical perspectives of prostate brachytherapy, specifically high dose rate. Afterwards, Dr. Buzurovic will speak about the physics aspects about HDR prostate brachytherapy. Okay, so here's the outline of my talk. So I'll just provide an introduction, and then I'll go through some of the indications of HDR brachytherapy in the monotherapy boost and salvage settings, and then I'll just end with a conclusion. So I always like to talk about a case. I think the case really makes me focus more about the talk. And just gives a little bit more context. So this was a patient, he's 72 years old. He had a prior procedure for benign prostate hypertrophy. And then he had a T1C, PSA 5.1, Gleason 3+4 prostate cancer. It's 7 out of 12 cores. He had pretty good urinary function. His IPS, his score was 6. He was not on Flomax. And then MRI showed that there was a small lesion in the right peripheral zone at the apex. And so you can see the lesion. It's outlined in red on the T2 and ADC sequences. And no ECE or lymphadenopathy. He kind of had Gleason 3+4 disease in the right base core, and so maybe that localizes a little bit more to high-grade disease. And he was interested in HDR brachytherapy. And so one of the resources that I often go to, are the NCCN guidelines. And the NCCN guidelines, it says what's the correct, radiation dose and fractionation for various NCCN risk groups. So this gentleman had 7 out of 12 cores. He had Gleason 3+4 disease. So he's kind of in that unfavorable intermediate risk cohort. Because he has more than 50% positive cores. He's interested in HDR, and it says that for HDR brachytherapy, 13.5 gray times 2 implants is an acceptable treatment option for treating the prostate cancer. Thinking a little bit more about high dose rate brachytherapy, there's indications for brachytherapy in pretty much all disease sites of prostate cancer. It could be used for low risk for patients who don't want to be on active surveillance, favorable intermediate risk, unfavorable intermediate risk, and this patient kind of fits in that select category. He doesn't have any extra prostatic extension or seminal vesicle invasion, so he likely has localized intraprostatic disease. But if he had some more worrisome features, then maybe he would be a better candidate for combination treatment. It can also be used in unfavorable intermediate and high risk for combination treatment. And then also radio recurrent settings, which we'll kind of talk about that in the end. As we all know, the basic criteria for brachytherapy that I use is the prostate size that's less than 60 cc's. And so now we have MRI, and so you can get a lot of those measurements from MRI. No prior TERP. And an IPS score less than or equal to 15. And so this patient, he pretty much meets all those criteria. So I thought he was actually a good candidate for high dose rate brachytherapy. And so, what is high dose rate brachytherapy? Basically, what it involves is inserting needles into the prostate. And through those needles, there's a radioactive source that goes through and deposits the radiation. It's a temporary implant. It's not permanent. So we're not putting radioactive seeds that stay in the patient forever. The radioactive source that's shown on the upper right, it does provide a very high dose rate, so greater than 12 gray per hour. And so treatments can be done within 10 to 20 minutes. And the treatment is controlled by an afterloader, which is a machine that kind of pushes the source to the various positions and allows it to deposit the dose in the target volume, which in this case is the prostate. So on the bottom, we just show that radium-192 source, the average energy, 380 keV, the half-life, and then some of the doses that we talked about. So 27 and 2 gray fraction, or 13.5 gray times 2 for monotherapy. So just really generally, and Dr. Buzurovic will talk a little bit more about this, there are 2 ways of giving brachytherapy for prostate cancer. One way is ultrasound-based brachytherapy, and the other way is CT-based brachytherapy. So I'll go over the ultrasound-based brachytherapy first. So the ultrasound brachytherapy, the basic workflows is that you have a transrectal ultrasound probe. You put it into the rectum, you insert the needles, you create the radiation plan, and then you deliver the radiation. The patient is only positioned one time, so they're in lithotomy the entire time. That's when they receive the radiation. And so the benefit of this procedure is that the patient doesn't need to move at all. So they don't have to wake up with catheters, they don't have to go to the CT suite, and then to the treatment room. The entire procedure can be done within 2 to 2.5 hours from probe in to probe out. But the caveat is that it requires a shielded OR. And so only really special, so it's just an added investment that needs to be made up front in order to do prostate HDR brachytherapy, because you need both HDR capabilities and anesthesia support. So just to go through the steps, we insert a transrectal ultrasound probe into the rectum. The patient is in lithotomy, and then we position the probe so that we can see the prostate clearly. We then insert needles into the prostate gland. So there's a really nice article from our friends up in Sunnybrook, where they have this 16 catheter configuration. It's 4 rows. Each row has 4 catheters. And you essentially just put the catheters just around the urethra, as shown in the image on the bottom right. And most implants can actually be, treated successfully with this needle configuration. The next thing that's involved is contouring. So we need to be able to outline where the prostate is. We also need to define the urethra, the bladder, and the rectum. And the contouring can be a little bit challenging because you have the prostate, but you also have a lot of needles. And as you can see, there's a lot of artifacts that are created from the needles. And so you want to make sure that you don't accidentally over contour the prostate. And it's really easy to do with these needles in place. And so, we've actually done a really interesting study where we looked at artificial intelligence to help us outline the prostate when the needles are in place. And so, in the image on the right, we have the contours in red, and those were the contours that I used when I treated the patient. And then we had an AI contours in blue. And what we were able to see is that for the image on the top, there's good concordance. In the middle, maybe a little less, just because of some, where the seminal vesicles are. On the bottom, the patient had a rectal spacer, and so the AI didn't do so well. There wasn't a lot of spacers in the training data set. But what we found is that the artificial intelligence may provide good contours. And on the image on the left, we show that when we had resident observers contour the prostate without and with AI contours, it seems like the AI contours may actually help them provide good contours for prostate HDR brachytherapy. And so we currently have a trial where we're randomizing new learners to the presence or absence of AI contours. I still check all the contours, but we're excited to be able to see if maybe AI can help with that important contouring step. So we currently have 16 out of 36 patients. Once everything is contoured, then the physicists do an important role of needle digitization. And so that involves just saying, where are the needles in the prostate? We kind of do this as an interactive process between the radiation oncologist and the physicist, so that we both feel confident where the needles are. And that's critical because if you don't digitize a needle correctly, if you're off by a couple centimeters, you can actually result in a misadministration. Then there's the planning aspect. And so the planning, the current optimizers are quite good. When what we're really looking for, we want to see the prostate V100 greater than 95%, the V200 less than 14%, the D.1 cc less than 115%, the rectum D.1 cc less than 85%. And these are the metrics that we currently use, and they're pretty much in line with what other groups are doing. And then we deliver the radiation. So as mentioned before, the patient is fully asleep. The treatment takes about 10 to 20 minutes. We monitor the patient from the control room, and the patient receives all the radiation and then we pull the applicator. And so once we pull the applicator, then we wake the patient up. And I think that that also, patients, if they don't have to, they would prefer not to wake up with catheters in place. So the other way of giving the prostate brachytherapy is CT-based workflow. And so a lot of facilities, they just don't have access to a shielded OR. And so they do the prostate HDR brachytherapy in a similar fashion to how they treat the GYN brachytherapy. So they have the ultrasound, we insert the needles, we then bring the legs down, but one of the steps that may be important in some practices is to have a urologist come in and do a cystoscopy. And the reason for that is that then you can make sure that the needles are still up against the bladder, even when the legs come down, and you can actually advance them. Then you suture the template, you put the patient onto a bed. I think that preferably the legs are still flexed so that the catheters don't come out. Then the patient may go to PACU. Then they get a CT scan. And what's important on the CT scan is to make sure that the catheters are up against the base of the prostate as you intend. And so I'm just showing you that one of the more challenging cases that we had a patient where we did the steps and then they got a CT scan and then the catheters kind of came out. You can see in that top right, the posterior catheter is probably out a couple centimeters. And on the top left image, you don't see any catheters around that fiducial marker. And so, we had to actually kind of push those catheters in. And then once we pushed those catheters in, we got a repeat scan to confirm, oh, we actually have the catheters in place. And then we do our planning, you can get an MRI scan, and then treatment. So the CT-based workflow, it is a little bit more involved. Spinal anesthesia may be a little bit preferable because that allows you to adjust the catheters, in a way that is less painful for the patient if needed. And maybe it's only about 20 to 30% of the time where you have to adjust the catheters. And so for this patient, we actually created a plan. He had a rectal spacer in there, so the rectal dose was really low. But we had a really good dose of the prostate. We were able to escalate dose to where the tumor was. So this was a boost plan for a patient. So this is just like a chart of, the ultrasound versus CT-based workflow, just telling a little bit of the pros and cons of each. So, the shielded OR, you do need that for the ultrasound. And the probe in to probe out treatment may be a little bit shorter for ultrasound. But on the other hand, with CT-based, if you are very good with parallel processing, you may be able to stack your patients. So you could have 2 or 3 going on at the same time. So it's kind of better for parallelization. Needle insertion is similar. Needle displacement may be more of an issue for CT-based treatment, but it can be adjusted. The digitization may be a little bit more difficult with the ultrasound based, just because of the artifacts. Contouring, it's kind of challenges on both ends. Ultrasound, there was needle artifacts. CT based, sometimes there's lack of contrast, and so an apical fiducial marker might be helpful. And then analgesia, post-op, CT-based, maybe spinal, maybe optimal in case you need to adjust your needles. So, I'm just going to go over a little bit of the clinical indications. So what are the most important studies that support the use of HDR monotherapy? And the one that really comes to my mind is this randomized trial that was done by Dr. Morton at Sunnybrook. Patients with low or intermediate risk prostate cancer were randomized to 2-fraction or single fraction HDR brachytherapy. About 170 patients were accrued between 2013 and 2015. Most patients had favorable intermediate risk disease. And really what the trial showed was that the two-fraction brachytherapy had better PSA suppression. So you can see those PSA numbers are lower on the red curve on the upper right. The nadir was 0.08 versus 0.89. And there was also better oncologic control. And so when you look at biological disease-free survival, and that includes both biological progression and death, there was almost a twofold less biochemical progression with the 27 gray versus the 19 gray. And so at 8 years, the biochemical progression-free survival is 83%, which is actually pretty similar to some of the external beam alone, where they don't get a hormonal therapy in RTOG 0815. It was around 80%. And some studies suggest that this difference is largely attributed to differences in local failure. So the local failure rates are much higher with the single fraction than the two fraction. And so really this trial just suggests that single fraction HDR monotherapy is not a suitable treatment option for localized prostate cancer. And this is despite adhering to the EQD2 calculations that we all study in our radiobiology class. Unfortunately, they seem to break down for patients who undergo a single fraction treatment. So two fraction HDR monotherapy could be considered. There's also an interesting trial, the PR19 trial, where two fraction HDR monotherapy is compared against single fraction LDR monotherapy. And it would be really interesting in a few years to see what those results seem to show. So for this patient, we gave him 13.5 gray times 2. He tolerated the treatment well. We treated the whole prostate. We met all of our urethral and rectal constraints. I really wanted to try to hit that tumor as hard as I could. And so, we were able to escalate that dose to 170% of prescription. I'm sorry, that GTV is more like a D90. And the PSA decline went from about 5 or 6 to about 0.89 at 15 months out. So far he's doing well. We'll continue to follow him. And so this was one of the questions that we had that was sent out earlier. So what is an acceptable fractionation for HDR brachytherapy, prostate? And so we are getting the poll.
Yeah, we'll wait until approximately 80% will answer. You see the results, right?
This is really cool. I've never seen this.
So when approximately 80% answers, we can end the poll and then show the results to everyone, and you can comment.
Okay.
What answer is
wow.
correct. Yeah. So let's wait a little bit. We need a little bit more. Please answer. That's how we track attendance also. So it's important to
Okay. Nice.
Okay, so we have almost
Okay.
80% participating. I'm ending the poll, sharing results.
Okay.
So majority, 45% answered B, 27
Okay.
fractions. Would you please comment?
Okay. That is good. And the answer is 27 gray and 2 fractions.
Excellent.
24 and 2 was used by some studies from Beaumont many years ago, but then they transitioned to 27 and 2. And that was what was tested on the Sunnybrook. So that's how we currently do it. Okay. So let me just go over the boost data. So this is a different patient. He's 71 years old. He had Gleason 5+4 cancer. And so, that's a pretty high grade cancer in 6 out of 12 cores. His MRI showed that there was a 1.8 centimeter lesion on the left side of the prostate. It was called PIRADS 5, and so that's the most aggressive. And there was some radiographic extraprostatic extension It contacted the urethra and near the rectum. His IPSS score was 2. In that apparent diffusion image on the bottom right, you can see how it's really, really dark. You can see it really lights up on the PSMA PET scan. There was no disease outside of the prostate. And so what is the data that supports doing brachytherapy boost? So there's a couple studies that are important. One is ASCEND-RT, and ASCEND-RT didn't look at HDR boost, but it was the first study in all of radiation oncology that compared extreme dose escalation, and so that's dose escalation beyond 78 to 80 gray, and in this case it was LDR boost versus just dose escalated external beam alone. It had patients with intermediate and high-risk disease. All patients got 1 year of ADT, and they all got radiation to the pelvis. The difference was really whether they got a total of 78 gray with external beam, or in these patients, they had an LDR boost. So there were 400 patients. This study did accrue patients treated about 20 years ago, mostly high-risk disease. And really the punchline was that LDR brachytherapy boost reduced the risk of biochemical failure. So at 10 years out, the biochemical progression, freedom from biochemical failure was about 85%. And it was more like 67% for patients who didn't get the brachytherapy boost. There was no difference in distant metastases or overall survival. And so some people say, well, is it really worth doing it if you don't see these long-term differences? And then the other thing that it showed was that in this study, there was a higher rate of grade 3 GU toxicity. So these are toxicities that require like urologic intervention to open a stricture. And there was a cumulative incidence of 18% for LDR boost versus 5%. The prevalence, the differences in terms of prevalence was lower, but this cumulative incidence really got a lot of notoriety. But it really set the stage and put brachytherapy boost on the map. There was another study that was reported a little later, and this was an HDR boost trial. It compared external beam radiation. Now the total dose of external beam was a little bit less than what we typically do now. Versus HDR boost. You can see the EQD2 numbers on the right. And this trial also showed that brachytherapy boost reduced the chance of biochemical progression. So at 12 years out, it was 48% versus 27%. The study also showed there was no difference in overall survival. But one thing that was interesting was that there wasn't actually any differences in severe toxicity at 8 years either, which made people wonder, well, maybe HDR boost may be a little bit safer than LDR. So then there was a recently reported trial, and I think that this is a very important trial, where they actually compared LDR boost to HDR boost. The trial was done by Juanita Crook and her colleagues at Kelowna. And it basically randomized patients with unfavorable intermediate or high-risk disease to LDR boost or HDR boost. All patients had pelvic radiation. They could receive ADT at the discretion of the physician. And patients who had LDR boost had it done after the external beam. And then for HDR patients had HDR boost done before the external beam radiation. And this was using 15 gray times 1, so single fraction. What this trial showed, it accrued 200 patients about. It was done in the MRI screening era. So 2014 to 2022, it's considered modern, mostly high-risk disease. It was looking at quality of life, not efficacy. But since we've talked about efficacy, in the prior 2 studies, I wanted to emphasize it here. And really what it showed us is that at 8 years out, biochemical progression-free survival was actually 85% for both arms. And most of the failures were because of regional disease or distant disease predominantly, the chance of local failure was about 2.7%. And so it was almost surgical levels. But, this trial suggests that you would need maybe over 1,000 patients to even see a difference between HDR versus LDR boost. And so, for all intents and purposes, they're likely almost equivalent. It was powered for quality of life. And so I have the EPIC urinary quality of life score on the upper left. And you can see that the HDR boost has a faster recovery of urinary function than the LDR boost. You can also see on the upper right that the HDR boost actually has less bowel symptoms pretty much throughout treatment. And the actual bowel symptoms, at 5 years is above 90. It's almost near baseline. And so that could be another advantage of HDR boost. Lastly, they did report on toxicities grade 2 and grade 3. And there was very low grade 3 toxicities, GU for LDR or HDR. And so what this study shows that with modern techniques and, of course, a very talented brachytherapist, the chance of toxicity is actually very low. And that both LDR and HDR boosts are acceptable treatment options for our patients. This is a study that we've done. It's currently there was a study that was called the FLAME study, where you can do external beam microboosts, and that's gained a lot of popularity. And we wanted to compare the dosimetry associated with microboosts. So that's in the green and the red, compare with some of our HDR brachytherapy boost patients. And what we are able to show is that you could get higher doses to the tumor with combo HDR. There's also lower doses to the bladder or the rectum, but there is higher dose to the urethra with brachytherapy boost. And so, this study seems to suggest to me that patients with larger tumors that are near organs at risk maybe can get more dose escalation with HDR brachytherapy boost and for microboosts. And then this is just a study just showing how the doses of combo HDR compared with other studies like SBRT GU005 or PACE-B combo HDR. And my take is that if you do combo HDR and you boost the dominant tumor by about 30% higher, you can actually get extreme dose escalation in a safe manner that you can't really get with SBRT. And so I still think that HDR boost is the best way to escalate dose to the tumor, especially for larger tumors. And this kind of just shows my thoughts about how microboost and brachyboost compare. Brachyboost, better local control for larger tumors, maybe less rectal toxicity, maybe there's less urinary toxicity with microboost. And this is kind of what we gave our patient. So he got ADT and abiraterone, pelvic external beam, and then HDR 15 grade ×1. And we were able to escalate dose of the tumor and still keep it off that rectum. And so he's done well after treatment. In terms of toxicity, I think a lot of people are concerned about toxicity for brachytherapy boost, and it is a little bit more involved. But I think this is typically what we do here. So pre-implant, we start tamsulosin a week prior to the implant if the patient isn't on it. On the day of the implant, we give them dexamethasone just to try to reduce edema, and then Keflex. And then after the implant, we make sure the patient can urinate before they're discharged. And if they don't pass the voiding trial, so this is about 10% of the patients, we keep the catheter in for about 5 days. In terms of post-op, they continue the Flomax. If they have any burning with urination, we put them on phenazopyridine, or we call it AZO. if they still have burning with urination and they're still on azo, you can always check a urinalysis or urine culture. If it's positive, which it rarely is, you could give antibiotics. If it's negative, you could double the Flomax or consider a Medrol dose pack. But I think that this can kind of really help most of the patients, as they get like 3 months to 6 months, the urinary function does get better. And our results kind of track with that BrachyQOL study. This is a question. So compare with LDR brachytherapy boost. HDR brachytherapy boost is associated with quicker recovery of short-term urinary quality of life, slower recovery of short-term urinary quality of life, greater biochemical control, or worse biochemical control. And we'll just wait to see what the poll shows.
Dr. King, I have a question for you.
Yeah.
I know you mentioned in your previous slides the criteria you have for your prostate HDR patients. If they have any comorbidities, like heart issues or something, is there something that you say no, not doing?
Yeah, I think, if they have a heart attack within 6 months to a year, they have to be on anticoagulation. So I say no. If they have if they're really sick, like kidney disease and heart disease and kind of heart failure, if their performance status is like a 1 or a 2, I might say no. Or if they're like 80 or something like that. It's really just trying to identify patients who are likely to live long enough to get the benefits of brachytherapy. I think that's really the challenge.
Thank you. So we have 88% answering. I'm ending the poll. So majority, 51%, answered A, quicker recovery of short-term urinary quality of life.
Okay, good. And that is the answer. It's really kind of similar quality of life, similar biochemical control, but that urinary quality of life comes back faster. And that's why for boost patients, I prefer HDR, because that urinary quality of life, can be really important. So the last is that I want to talk about is salvage setting. So we're seeing a lot of these patients. Like, I think I've had days where I see 4 of these patients in consult, and it's especially with the PSMA PETs. And so this is a 65-year-old. 4 years ago, he had intermediate risk prostate cancer. And he had 6 months of ADT and external beam, 79.2. So it's totally within standard of care. He had radiographic T3A disease, but clinically it was more of a T2. His IPSS score, and what happened was his PSA kind of came down from 6 to 0, and then it went up to about like 3.2. Over a period of 5 years. And you can see it on the graph on the upper right. He had a biopsy. So I always want my patients to get a full workup. And so that includes a systemic biopsy plus targeted biopsy. And so this patient actually had intraductal carcinoma on the right base, the right mid, and the right apex. He also had an MRI where it showed, this is an ADC image, but it showed diffusion restriction in the right posterior prostate. And then he also had a PET scan, which showed PSMA avidity in the right posterior prostate. But there wasn't any disease in the nodal or distant sites. So he comes in and, he's really young. He's 65. Like if a urologist saw this, they'd be like, oh, they should have never had, radiation when they're in their early 60s. And so, what is the role of HDR brachytherapy? And so, this kind of goes into a little bit more of like the general, time frame is For patients with biochemical recurrence after prostate radiation, this can be about 20 to 30% of patients at 10 years. It could be 40 to 50% at 20 years. So it's a lot of patients. But among those patients with biochemical recurrence by nadir +2, over half of them have localized disease within the prostate. And this is based on PSMA PET. And so this was a study where any patient with biochemically recurrent prostate cancer had a PET scan, and it was prospectively reviewed. And after radiation, 63% of patients had disease in the prostate. This is compared with 14% who had radical prostatectomy. On the right, it also showed that, about 62.8% of patients had a localized recurrence, and this is after LDR brachytherapy. So what are the treatment options for radiorecurrent prostate cancer? Well, there's a lot of them, and there's not a lot of consensus on what's the best one. Some patients may get observation. They might go down to intermittent ADT, and I still think the majority of patients can do intermittent ADT. But other treatment options are local salvage. And the reason why we think about local salvage is that in some cases, it's actually curative. But the problem is that any type of local salvage treatment is associated with toxicity. So this was a nice study, like the table on the right. It was the master meta-analysis that looked at relapse-free survival and severe GU and GI toxicity for radical prostatectomy versus cryo, HIFU, SBRT, HDR, and LDR. And what it really showed was that compared with salvage prostatectomy, reirradiation may have less GU toxicity. So instead of 21% of patients with kind of permanent urinary incontinence, it's more like 5 to 10% or 10 to 15%, similar oncologic efficacy. So at 5 years out, and of course, this depends on the type of patients you see, about half may be cured. So what are the ideal candidates for reirradiation? These are patients, these are just my thoughts. They have localized disease on PET scan. They don't have any grade 3 GI or GU toxicity. So if you see a patient and he's getting up like 10 times at night, don't offer reirradiation. He's going to have a really tough time. His IPSS score should be less than 15. His PSA should be less than 10. The doubling time should be greater than 6 months. And so if you see a patient with a doubling time of 3 months, his chance of cure with reirradiation is probably 0%. He probably has micrometastatic disease. And then the last one is biopsy-proven intraprostatic disease. Many of these patients are kind of in their 80s or late 70s, and they don't want to get the biopsy. But I think the biopsy is important because sometimes the biopsy will show much more disease than you expect based on imaging. The other thing that I think is important is that in many of these patients, you can actually do more focal treatments. And focal treatments are nice because it can probably reduce toxicity. And maybe that's all that's needed for some patients. So the best candidates for focal treatment are patients who have, concordant disease on 3 modalities. So it's PET scan, MRI scan, and biopsy. They don't have any systemic biopsy showing disease outside of the PSMA PET or MRI defined lesions. If they're advanced age or marginal urinary function, I usually try to do focal treatment if I can do it. On the right, it just kind of shows a little bit about different types of focal or partial gland ablation. I think it is the right answer for some of the patients. Just make sure you use a generous margin, like I use 8 millimeters, because you never want to treat something and get a marginal miss either. There's different ways of doing focal reirradiation. You can do LDR, you can do HDR, you can do SBRT. In terms of HDR, it does require 2 implants. So single fraction reirradiation doesn't work very well. It does allow for pronounced dose escalation, and it can allow for treatment of extracapsular disease or seminal vesicle invasion. And that's something that can't be done with LDR. And you can probably still get higher dose than you can with SBRT. And so the image on the right, this was a patient treated a couple weeks ago. He had some PSME uptick in the prostate, but also the seminal vesicles. So we were actually able to insert needles into the prostate and the seminal vesicles. We did treat the prostate because he had pathologic disease on the left apex and left mid and left base. And then on the bottom image, you can see how we were able to treat all the way into the seminal vesicles. And this was just, the initial case that I showed you earlier. This patient, he was on our protocol who got 10.5 grade to the prostate. He got at least, about 13 grade to where the tumor is, so 27 and 2. He got 6 months of ADT. The metrics are on the right. I usually don't try to get that V100 greater than 95% just because, some patients, maybe 1 in 10 might have some serious grade 3 toxicity, especially GU. But these are the results that we had. Fortunately for him, his PSA went down, and 3.5 years out, it's still undetectable. And so he's actually done pretty well. He had some grade 1, grade 2 toxicities, but nothing like a grade 3. So he's one of our success stories, and that's fortunate because he's really young. So reirradiation is an increasingly viable treatment for radiorecurrent prostate cancer. It can be curative in some, and it could delay the need for ADT in others. And then focal treatments may reduce the risk of reirradiation for patients with low volume disease, but accurate targeting and generous margins are important. So this is the last question that I have. Which of the following is correct regarding workup for prostate reirradiation? So PSA doubling time greater than 6 months, biopsy proof of intraprostatic disease, no current GI or GU toxicity, no extraprostatic disease on PSMA PET scan, or all of the above.
So Martin, do you usually use HDR currently at Brigham, or you sometimes also do?
Yeah, I usually use HDR. I do have a couple patients who were in their 80s and they just didn't want to go under twice. And so for those with really focal recurrences, so they have 1 or 2 out of 12 positive cores, and it looks like it's really focal, I might just do LDR. So I just treat the area with an 8 millimeter margin, and that can get them really good treatment. They have actually pretty minimal toxicity with it, and they only need to go under once. And so that can be the preferred treatment for patients with low volume disease.
Okay, that's great. So we have 83% participating in the poll. I'm sharing the results. So majority answered all of the above. E.
Okay, good. So yeah, the answer was all of the above. And so there's,
Great.
yeah. Some people might say, well, if they have the MRI and PET scan, why should they get a biopsy? But it's just important to, sometimes you're just surprised. Maybe 20% of the time there's a small lesion, but every single core is positive, and you just don't want to treat that one lesion and just have that PSA come right back up. I think that really trying to do your due diligence, just because there is a chance of toxicity with this. And so you want to make sure that you select the best patients. So in conclusion, HDR brachytherapy can provide optimal and consistent dosimetry. Monotherapy can be used for favorable risk or radiorecurrent cancer, but 2 fractions are required. And it's a great boost treatment for patients with larger tumors. And then the last slide that I have, The utilization of brachytherapy has been declining, and this is because of limited resources or expertise, as well as advances in beam. But this is just a slide just to show that even in 2025, you can have a pretty active brachytherapy practice. And so it's been wonderful to be able to do a lot of prostate brachytherapy, even when it's even when there's challenges. So I just want to thank the organizers for inviting me, and Yvonne and our fantastic team. And I will stop sharing so that Yvonne can share his wonderful work.
Thank you so much, Martin. That was very comprehensive. I love all your examples and explanation. It was really great. One question maybe I have as a follow-up. What's the time difference between implant 1 and 2?
So it's usually like a week to 2 weeks.
Okay.
Is usually the time that's preferred.
Yeah, excellent. Are you available to stay after Ivan's talk?
Yeah.
The questions? Awesome. Yeah. Thank you, Ivan. Go ahead, please share. Excellent talk. It was great.
Thank you.
I hope you can see my screen, and
Yes,
I
we
will
can
be ready
see.
in a second.
Perfect.
Okay.
Excellent.
Hello, everyone. Thank you, Martin, for giving such a great talk. Thank you, Natalia, for organizing all this. This is really amazing. And thank you all for participating. Should I say Dobry večer?
Very beautiful.
I will-
Dobry večer. Awesome.
I will talk about the medical physics aspects of HDR brachytherapy prostate procedures. I will talk a little bit about and outline what is necessary to establish the program and what is necessary for people who have established brachytherapy program, how to expand their brachytherapy program. I will talk about the equipment, some regulatory requirements, some necessary documentation, and after that I will talk about a different workflow, about the multiple type of imaging and how to utilize those images in HDR prostate brachytherapy. But before that, I will continue when Martin stop and present in 2-3 slides our brachytherapy division. We deliver up to 1,500 fractions of brachytherapy per year, and we treat about 600 patients with various type of brachytherapy techniques, and we are capable of delivering 70 fractions per week. So this is our total number of patients, and I outline HDR and LDR prostate. And thanks to Dr. King, we actually increase number of HDR patients. More than 90% of all treated patients are basically HDR patients. And in the previous 3 years, combination of LDR and HDR prostate brachytherapy came to 172, and the HDR prostate procedure in the previous 3 years was 152. This number is continuously increasing since only up to date we treated 40 LDR prostate patients. So you can see that our brachytherapy clinic is pretty busy, pretty intensive, thanks to the whole team and our excellent physicians. So learning objective of the future slides will be to understand the medical physics roles and responsibility in HDR brachytherapy, to identify which equipment and infrastructure is necessary to start or to expand the program. And we will give a pros and cons for CT-based and real-time ultrasound workflow from a technical point of view. And we will, at the end, finish with some recommendations. And of course, we will not forget about the safety procedures that are necessary to establish such treatments. In general, role of medical physics to be integral part in every HDR step, from setup, planning, QA, and delivery, to ensure dosimetric accuracy and patient safety, to coordinate with the members of all teams, and to apply the current standards, in our case, APM, ABS standard, and NRC and state regulations into a clinical practice. So we know that HDR prostate brachytherapy is a technique in which welded source is sent through the transfer tubes inside the cancerous tissue, in this case inside the prostate. The source stays at a certain position, which is called dwell position, for a certain number of seconds, that is called dwell time, and basically paint the dose, allowing for a high level of sparing of a healthy tissue adjacent to the organ, and to have high conformality of dose and a short treatment time. After this process, source is safely returned to the device called afterloader. So I will skip to the program startup and infrastructure. Unfortunately, I cannot talk in depth, but here I will outline all necessary equipment that is required to start or to expand the HDR program. It is necessary to have a shielded treatment room, or dedicated, or a Linac room. We had a boat, and our experience with sharing a Linac room for brachytherapy was not too successful, but of course, we have to do what we have to do. It is necessary to have a device that is responsible for automated delivery of a dose, which is HDR afterloader, to have a treatment planning system, secondary computer for independent plan verification. These requirements vary from country to country, and it is always good to refer to the, I think in your case, probably ESTRO and national verification. For instance, in Canada, it's not required to have an independent secondary physics check to start the treatment, but it is always good to double check your dose calculation. Imaging modalities in these days must, so CT, MRI, ultrasound for HDR prostate is really important. We will talk a little bit in depth about this. It is necessary to have intraoperative procedural equipment, radiation safety equipment, monitoring system, emergency equipment, and anesthesia. In order to implement the whole HDR brachytherapy procedure and process in a clinic, it is necessary to develop, medical physicists develop HDR quality management plan that includes acceptance QA procedure, annual, monthly, daily procedure, treatment plan, pre-treatment and emergency procedure policy, and chart QA, which is end of treatment checks. All these documents should be converted to a policy for a safe implementation. Just 2 slides about room design and shielding. It is dedicated HDR suite should comply with the NRCP 151 shielding requirements. It is necessary to have intercommunication and monitoring equipment, and of course, at the treatment console, therapists should know the status of radioactive source. Is it in progress? Is it in safe, etc.? This is a basic outline. And based on that, shielding should be calculated. That's the initial process. In the case when the linear accelerator volt was used, shielding for HDR unit with a maximum energy of 1.1 MeV and average energy of 380 kV is completely sufficient. But what is necessary, if you already have a vault, to do annual check of and the survey of your shielding design. To go directly to the HDR prostate equipment, it is necessary to have the HDR afterloader, transfer tubes, and catheters. We will talk a little bit about details of these pieces of equipment. It is necessary to choose proper perineal template and the stepper device that will hold the template, and the treatment planning system. Current treatment planning system calculated those based on TJ43U formalism, and some treatment planning system offer model-based treatment planning that is outlined in TJ186. So for a prostate, it is not necessary to calculate those using TJ186 and TJ43, where everything is considered as water, is most likely not going to bring deviation for our calculation and publication more than 1% for a prostate. What is interesting, if the patient was previously treated with LDR seeds, and recur and we treat with HDR, those LDRCs will locally enhance the dose. And we have a very interesting, nice Monte Carlo study on that topic. In addition to this, quality assurance tools such as well chamber, electrometer, phantom should be calibrated and ready. This is actually a setup for our HDR intraoperative procedure. We can see transrectal probe that has two crystals, sagittal and axial. So it means that we can see the images in sagittal and axial. This system has an actuator. It's a motorized image acquisition in a sagittal mode, which is good because motorized imaging acquisition in a previous treatment planning system tends to vertically displace the anatomy, and image reconstruction was not the best. We use this device called stepper to stabilize the probe and to put perineal template as a needle guidance. So this is not some physician likes to do not use a stepper for these procedures, just a template, but this allows for a stability and robustness of a whole process. So there are different types of templates. Templates, as I said, guide the needles. So we use these needles to guide. This template is called Martinez template, and it has a locking pin that locks the needles in place. So displacement or in a superior inferior direction of the needles during the procedure is not possible. The other templates are also possible to use. For instance, we tested this template. This template was able to lock all needles in place at the same time. But as you can see, there are so many different pieces, and our surgery tech had a really big problem trying to put all these together. And as we have so many HDR prostate cases, possibility to lose those pieces at CPD is high. So we decided to go with a less complex but more reliable template. Here you can see my sketch for a calibration, and I'm going to talk briefly about the calibration of the ultrasound system for a prostate brachytherapy. We basically have three templates. That one is the physical Martinez template in this case, virtual template in the treatment planning system, and the ultrasound template. So the role of the physicist in calibration of these three pieces of equipment is to make sure that all these templates correspond to each other. That means that when the needle is inserted in, let's say, D2, the needle should show up in an ultrasound and in a treatment planning system at the same place. There is a procedure in APM task group 128 how to do additional quality assurance tests such as accuracy at a different penetration depth, etc. And I refer to the physicist who's supposed to perform manual QA check to that document further. So which catheters and markers should be used? We use ProGuide plastic needles because they are flexible, and in order to insert those needles, it is necessary to put inside a steel insert or an obturator that will allow for a easy penetration or insertion of the needles. And all these needles should be properly QA. This is one gaphchromic film when we deliver the treatment plan, virtual treatment plan, and try to assess the accuracy and to assess proper reconstruction. If the needle is not properly reconstructed or calibrated, we can physically displace the whole implant. That can lead to the misadministration or even to a medical event. The dummy marker or proper markers should be always used. For instance, I will show you this, what can happen if these non-CT based markers we use for a procedure. You can see that quality of a CT scan degrades significantly, and that leads to suboptimal visualization. So in this case, we had to take out the wrong marker, put the right marker, and continue with the procedure. Treatment planning system. This is our treatment planning system. It's called Central Prostate. It is capable of needle reconstruction, DVH creation and optimization, and it works based on TJ43 formalism. Another treatment planning system that we use for the CT-based procedure that we do not have that many, maybe less than 2-3% currently, can do model-based dose calculation. But for ultrasound-guided HDR procedure, model-based calculation is not necessary. TJ43 stays the predominant dose calculation. Other consideration and equipment in implementation of the program include possession of a calibrated valve chamber, transfer tubes, and verification phantoms. It is necessary to have a trained personnel, and the American Brachytherapy Society recommends more than 10 supervised HDR prostate procedure for competency for a medical physicist. Ultimately, commissioning end-to-end test is the ultimate verification of the proper setup of the whole system. So I will talk briefly about imaging. Imaging modalities used in HDR prostate are CT, transrectal ultrasound, and MRI. CT has a high geometric accuracy and easy catheter reconstruction. Transrectal ultrasound imaging allows for a real-time guidance and intraoperative HDR procedure, which allows for adaptation. Needle reconstruction is rather complicated with the transrectal ultrasound images, but the benefits over CT guided procedure are so good, and we will see a few slides about that. MRI is best for a soft tissue contrast, and it's usually combined with those other two modalities. So it is necessary to commission the system based on APM recommendation 53 for proper image registration. Just to remind ourselves that the registration is a procedure in which two or multiple imaging sets are placed into the same coordinate system. So when we use imaging for treatment planning, for instance, for a CT, we should use slice thickness less than 2 millimeters. Usually, rule of thumb would be the half of a standard pelvis protocol for visualization of the catheters, and to allow the accuracy of a source placement of 1 millimeter. So basically, HDR procedure is mostly delivered under general anesthesia in the lithotomy position. Foley catheters is inserted to better visualize urethra, and catheters are placed individually under the ultrasound guidance, but also for a CT-based procedure, ultrasound can be used for replacement of the catheter. So we come to our first question, or actually question number 4.
Do you mind reading it so it's also transcribed into Ukrainian?
Which APM task group report introduced model-based dose calculation? TJ43, TJ59, TJ186, and TJ303.
Thank you.
Just to remind, model-based dose calculation is the dose calculation when the heterogeneity corrections are implemented.
So we have 80% answering, and the answers are actually split between C and A.
So correct answer is C, because model-based dose calculation is described in an outline in TJ report 186, and we do not necessarily need to use that dose calculation in the treatment planning for the HDR prostate. Let's go through the basic benefit of HDR-based for CT-based HDR prostate workflow. So this workflow is still mostly used in many institutions due to the reliability, and in such cases, catheters can be inserted under the ultrasound guidance if there is no dedicated or room for brachytherapy. Patient has to be moved once, and patient has to be moved post-treatment planning for a treatment delivery. This actually displaces the catheters, and it might result to unfavorable delivery of the treatment plan, and those errors is very hard to detect. For instance, when the needles are delivered in the lithotomy position, when the patient is scanned, when the legs are down, needles tend to retract, and there is additional effort in the treatment planning process to try to compensate for those displacement of the needles. As I said, in this case, we will take less than 2 millimeter slice thickness CT in order to reconstruct the images, to reconstruct the catheters in a best way. Treatment planning consists of several steps. After contouring and catheter reconstruction, there is activation, normalization, optimization, measurements of the catheters as a QA, export of a treatment plan, and the treatment delivery. Catheter reconstruction in the CT is not complicated, but what is important to do is to go from a catheter end or a catheter tip from a distal or proximal end and follow those. You can see here template and very nice and symmetric distribution of the needles. And after the catheters are reconstructed, treatment plan can be generated, and it is not uncommon that the contouring is done using MRI images whenever institution has a possibility to perform MR images and MR CT registration for a proper delineation of the target and organs at risk. The last process is to generate a treatment plan, and the treatment plan is reviewed by physician. And you can see here that it is possible to very nicely save the urethra and to give a good dose to the whole prostate. Unlike the CT-based treatment planning, in ultrasound-based real-time workflow, it is not necessary to move the patient. Needle insertion is done in the same position as a treatment, and this workflow allows for optimization and adaptation of the dose. At the end of the procedure, if there is a cold spot in the treatment plan, easily needle can be added to compensate for and to generate the most optimal treatment plan. So I will briefly go through this procedure. So once when the probe is set up on a stepper and stabilized, we actually take the first images to assess if there is any issue such as pubic arch interference, if the visualization is proper, and in that case, a template is aligned and we do image acquisition. When the image acquisition is done, the geometry of the prostate was formed, so we define base and apex of the prostate and the reference plane in order to allow for those calculation within the space of the prostate. Needles are inserted in real time under the real-time guidance, and image acquisition is done post-needle insertion. Once when the contouring is done, physicists work with physician to reconstruct the catheters, and once the catheters are reconstructed, and actually if there is a displacement of the catheters, we can adapt those catheters to the real position. So basically the calculated dose is very close to actually almost identical to the delivered dose without because the displaced catheters can be detected and corrected in this process. So inverse, another important role of a physicist to if the inverse planning software was or inverse planning methodology was used to properly adjust the whole parameters, and that can save 15, 20, even half an hour in a treatment planning. And as a result of that process, we have a semaphore indicating the treatment plan reach all goals that Dr. King previously described. Post generation of the plan, we review the metrics, and once the plan is approved, second physicist is going to check the plan, and when the plan is ready for a treatment, we will continue to a treatment. And now the last question is, which workflow supports intraoperative plan adaptation? CT guided, ultrasound guided, MRI guided, or COM-beam CT guided?
Ivan, while they are answering, I wanted to ask you, do you know if anyone is doing MR-guided intra-op planning?
So I don't think so, but MRI guided intraoperative planning was initiated in our institution in
Yes.
2000, and Dr. Amico was doing that
I remember that.
with Robert Cormack. Those are the, and you wouldn't believe, if you look at the MRI images of that time, you would probably ask yourself how they were able to identify anything. But MRI guided prostate brachytherapy was first established in this institution with Dr. D'Amico in the early 2000s.
Yeah, but I'm just curious if anyone is doing it anywhere else. I remember looking at the images, and was challenging is those needles were, plastic, and they were bent all over the place. It was very difficult to reconstruct the catheters. So that was one of the big challenges.
So basically, I don't know, Martin, do you know if any institution is doing MRI guidance? I think MRI ultrasound combination is a current high-tech standard.
Yeah, I think the only one that it did in MRI was, or that has the most experience, is Princess Margaret.
Okay.
But I think they use more ultrasound based now. MRI is hard just because it's really time consuming, and Princess Margaret had a nice paper that showed that there was a lot of catheter movements in between, even moving the patient from the MRI suite, to the to the treatment room, and they take another MRI and things deviate. So it's challenging.
Okay, so we have 88% answering, amending the poll, sharing results. So majority said trust guided.
Correct. That's the correct answer. And the treatment delivery consists. I will try to finish very quickly because we are running out of time. So treatment delivery is loaded with safety checks, because that's the last step before any possible mistake is caught. And that is very important for a program to establish proper pre-treatment quality assurance procedure, safety pause, and the proper procedure before the button was pressed for a treatment. And general recommendation for HDR prostate brachytherapy program: it is necessary to have standardization and compliance. It is really important to establish proper quality assurance and safety programs and procedures, to have a proper documentation, and to establish the workflows of these procedures. These procedures can be done in various ways. Even a single CT-based or ultrasound-based procedure can be done in different steps, but it is important for an institution to have a unique way of doing these procedures. And education and continuous improvement is really important. Key takeaways from the physics aspect of HDR prostate brachytherapy: So HDR prostate brachytherapy demands precision in every step. Physicists ensure dosimetric integrity and patient safety. CT and ultrasound workflows are both effective and both can be implemented, but real-time ultrasound-guided prostate increase is getting standard increasingly. And the quality assurance and checklist are important for a safe operation. And future development will be in unifying ultrasound with MRI workflows and probably more adaptive HDR, more complete automation of treatment planning, and very likely in soon artificial intelligence dose optimization. Thank you very much from Boston.
Thank you so much for such an excellent lecture. It's a great overview and amazing amount of work you've done at Harvard. So very impressive. Thank you, Ivan, for sharing. Excellent. So I'd like to open the floor for questions. If you have any questions, please type them in the chat, or you can also turn on your camera and microphone and ask our great speakers. So while people are preparing, maybe I will ask a question about pre-planning. Do you guys do any pre-planning, and what patients do not qualify for the implant?
Yeah, I haven't really done that much pre-planning for prostate HDR. I think that the most thing that we might do is, we might try to take an MRI and fuse that onto the ultrasound. And when we see where the tumor is, we can just make sure we put a lot more catheters where the tumor is, and maybe give that a little bit more dose. But we haven't really done any formal pre-planning like we would do, or like people do for LDR.
Mm-hmm. So you skip that step altogether, mostly?
Yeah.
What about pubic arch interference, or like size of prostate? Doesn't matter?
Yeah. Usually I try to do it 60 cc's or less. Sometimes if there's a patient, like a boost patient, if they have like a 70 or 80 cc gland, but they're going on hormonal therapy, some of the hormonal therapy are really potent. Might make it down to 40 cc, so it might be implantable. I think that there are some patients with really large prostates where it's really hard to do it. But there's been a couple cases where they can give like a full external beam dose plan, so they can get 70 and 28 to the entire gland, and then you can do a focal HDR just to where the tumor is. And so there was some data from Princess Margaret where they did these focal HDR implants, and that could be a good tool to escalate dose for patients who otherwise wouldn't be good candidates, like because of large gland leading to pubic arch issues and stuff like that.
Do you ever run into issues where if you use like rectal spacers and that causes pubic arch interference, especially with template guided implants?
Yeah, so that I would say 90% of the time we can get around it, just because they're also on hormonal therapy and things shrink down. But there's always 5 to 10% of the time where it becomes, you're probably sticking needles into the patient double the number of times just try to get it over the arch.
Sure.
So that could happen. But I think there was only one time where I thought like it was really challenging, but we were able to get it in.
Martin, from your experience of sticking needles, how long does it usually take to get good at it? Like, let's say if we organize observerships for Ukrainians, and what's the approximate time that you can really get good?
Yeah. I think that it does take some time, but I think a lot of it is just trying, I mean, a lot of it does come with experience. Like, I think when I started, the quality of the implants weren't that good. It'd be hard for the physicist to close the apex or the base. I think that if you start doing like, maybe like 20 to 50, consistently, you'll kind of get a sense on which implants will go well, and which ones you might need to add an extra needle here or there. But I think it does take time, but I think, the goal would be to try to get the needles in within 20 minutes. And I mean, our current fellow now, like he could do it in 20 minutes. He's fast. And so, but I think it's kind of working with the collaboration with the physics too. Like Ivan always lets me know, like, oh, I don't think we can treat that, or, just setting our expectations. And if there's any question, just putting in an extra needle, I think is usually the way that we do it.
Do you think pre-planning would help in those cases where you're still not very, very good?
Yeah.
Yeah.
I think the challenge with pre-planning ultimately is probably can be helpful. But the challenge is that a lot of times the prostate will just change in shape. And so it usually gets longer and it gets thinner. And so pre-planning might tell, like, oh, you need to put a lot more needles than you might need, actually, because the prostate dimensions change. But I think that, maybe a combination of the two, sitting down before you put the needles in, just looking at the ultrasound image, and some places will say, well, let's just put needles in these positions, and then, but just making sure that you adjust on the fly as well. But probably pre-planning could be helpful.
Yeah. And Ivan, what do you think? How long does it take for physicists to master planning?
So once when we have a physicist in our group, it takes 6 months with this workload to be over continuous training to be able to perform physics tasks. We have a certain standards, and we have a very high standards. We do not let the physicists do anything independently unless the certain tasks such as treatment planning should not be more than 15-20 minutes. We cannot extend anesthesia time because physicists are not prepared. So even board certified physicists requires at least 6 months of training for these procedures to be done at the highest level. In some institution, when you have enough work time, and when you can do 1 case or 2 cases per day, and you don't have to worry about the other treatment around you, you can extend the time and be more relaxed. But we are like the best NBA team. You have to score and win.
Yeah, good job. Yeah. That's tough, 6 months. Yeah, that's but I hope maybe they can also learn on phantoms, right? You have some phantoms and they can practice taking needles.
That's true. But the mindset is shaped best in the OR. So when I have a resident or trainee with me, and when the trainee does not need to do some actions, their mindset is not there. So they sit in a cockpit, the perspective is completely different. So also it is really necessary to have people who are willing to overcome all those possibly pressure and issues, and because every single case is a different challenge, and you have to overcome the challenges that come with a single case.
Yeah, great answer. Serhii, did you want to ask questions? Sorry, I want to give you a chance to ask a question.
Yes, thank you very much for the great lecture and for sharing your experience. That was wonderful. I was curious, you mentioned one patient performing LDR treatment for this patient because he didn't want to travel twice. So just out of curiosity, what is the pro and cons for LDR treatments from your perspective, including such thing as the cost of the treatment? I was wondering about that. Thank you.
Yeah, I think it's, I mean, that's a really good question. So I think, LDR is good if patients have like a small focal lesion on the side of the prostate, because then you just put in a few seeds and you can get a really, really high dose. I don't think it's as good if they're at risk of having disease outside of the gland. So if their PET scan has seminal vesicle invasion or even like extracapsular extension, then I get a little bit more worried that I wouldn't cover everything. So then I usually transition to HDR then. I think that LDR is also challenging if they have a really small gland. And so some of these patients after radiation and hormones, it just shrinks down. Whereas HDR, the dosimetry is a little bit more consistent. So I tend to prefer high dose rate. Like even if I have to treat the full gland, I would just do high dose rate. But if there's somebody that has like if they're like 82 and they have some mobility issues and there's a small prostate tumor on one side with 1 out of 12 cores, like, I'll put in the LDR and they seem to do just fine with it.
And maybe we didn't discuss LDR at all, Ivan. Maybe like in few sentences, your procedure for LDR, what type of applicators you use, and
So for LDR, we use actually the same setup, same treatment planning system. Everything looks the same, but the treatment planning system works in a different way. The physician uses metal needles, and we use needles that we load in the OR using a system we do not do preloaded needles and pre-planning. So we do real-time treatment planning for LDR as well.
And you use iodine 125.
We do use iodine 125. Peter Orio is using palladium now, and there is this initiative for using of cesium 131. However, we do not have experience with the cesium 131 for a LDR prostate. We use cesium 131 for a brain, for a spine, pelvis, etc.
Yeah, excellent. And yeah, go ahead.
I'm sorry. I was just wondering if you can very roughly estimate that having one procedure or two, having once to book or rooms with the staff and having to have pay for the sources itself, what would be beneficial from that perspective, and also from maybe some consideration about radiobiology for this treatment when you have decaying slowly source in the prostate.
Yeah, I think it's an interesting point. The LDR is probably the most ablative treatment there is. It has like the lowest PSA naders compared with any form of treatment. And, maybe patients with more radio-resistant tumors, putting in seeds right in the tumors could be the most ablative way to get rid of it. We did get to a point where we just had such trouble scheduling cases where that was part of our impetus to start doing some LDRs for these salvage patients, and that they were, 80, like 82, and they just couldn't hold their Eliquis multiple times. But I think it's still an open question. I think, the best data for radio-recurrent prostate cancer is LDR with Juanita Crook's study, RTOG 0526. We've also have seen some toxicities with whole gland HDR salvage. But I think it's still an open question. There's a lot of variability. A lot of people are doing SBRT for these right now. None of us really can agree on what the absolute correct treatment is.
I still remember these big discussions at the ABS meetings and then at Astro, where big prostate physicians stand up and then argue, oh, SBRT or
Yeah,
EBRT
yeah,
or Brachy, HDR, LDR. So it was very
yeah,
interesting to observe this, and it's still happening. Huh?
yeah. It's
No,
still
no good
happening.
answers. No good answers.
No good answers. That's right.
Awesome. That was really, really nice discussion. Great lecture, amazing lecture. And I hope we will give an impetus for Ukrainian radiation oncology community to start prostate HDR treatments in Ukraine. I think right now it's a challenge to order sources, so LDR is out of the question for now because of the war, but HDR is possible. And I know multiple centers are very interested and curious to start this, and we'll be possibly organizing some training for them, observerships for them to get.
Yeah, of course.
Yeah, so
Yeah,
if you are open to train, we will ask for your help.
yeah. No, I think
Natalia,
observerships are.
maybe it's good for you to know that HDR afterloaders can be loaded with the cobalt 60
Yes,
sources
yes.
with extremely long 5.26 years. So that means that there is no need for replace a source in 3 years.
Yes, yes, yes. So actually, most HDR afterloaders use cobalt in Ukraine because of that reason. But some are using seven. There are 7 using iridium. Yeah, but yeah, it's a very interesting topic for many centers, and they're excited to get started. And I'm wondering, maybe the last question, do you know of any workshops or maybe something special organized how to get started on prostate HDR training?
Yeah, I mean, there was a recent the prostate brachy school, but that has just passed,
Yes,
unfortunately.
we missed that one.
But I think that there's always kind of some more sessions at like the ABS meetings, and that's always still a good time. Or maybe in the European, they also have some very, very good sessions through the Euroject team. And I think they've also always done a fantastic job with teaching, and so that could be another great resource. Yeah.
Yeah, we see a lot of comments. Thank you. Great lecture, amazing lecture. Sincere appreciation for excellent lecture. Thank you a lot, both of you, for excellent lecture. And we will meet next week then for breast brachytherapy. Bye, everyone.
Okay.
Thank you,
All right.
everyone.
Bye.
Thank you.
Thank
Thank you
you.
so much for teaching. It was excellent.
All right. Appreciate it.
Bye.